Welcome back everyone, and hi, my name is Chan. In today's video presentation, we will be discussing anesthesia as a common popular topic in the MRCS exam. So let's get right into it. Today, we will be covering the basic definition and types of anesthesia, exploring the contraindications of neuroaxial anesthesia. We will then dig deeper into today's main learning objective, which is the local anesthesia, as well as recognizing the signs of toxicity and its pertinent management. Anesthesia is a word originated from Greek, which literally means loss of sensation. On a day-to-day clinical practice, we came across a variety of methods for anesthesia, like local, regional, spinal, epidural, and last but not least, general anesthesia. Dynamic anesthesia can be adopted to achieve a better anesthetic outcome as part of the ERAS protocol, which stands for Enhanced Recovery After Surgery. Let us take a look at local anesthesia. It covers only a small area of the body for easily accessible nerves or nerve endings. The preparation of the local anesthetic agents can be found in the form of drops, such as Prilocaine drops, which indicated for eye pain, Prilocaine nasal spray for a pre-cauterization procedure in the case scenario of a nosebleed. Some clinicians even use amla ointment prior to a procedure like ABG in pediatrics. And lastly, the local anesthetic injection prior to dental abstraction are the few examples of how local anesthetics can be best utilized to achieve a good analgesic effect while maintaining the consciousness. The three most commonly used local anesthetics agents in the clinical practice are lidocaine, bupivacaine, and prilocaine respectively. Lidocaine is essentially an amide compound and also a class 1B antiarrhythmic agent, which can be used to treat ventricular tachycardia. It functions by blocking the sodium channel of the pain neurons to prevent depolarization. This chemical compound is metabolized in the liver, protein-bound, and is excreted renally. The dose can be increased when combined with adrenaline to limit systemic absorption, and because of the protein-bound nature of lidocaine, there is a risk of toxicity in liver diseases, low protein states, and metabolic acidosis due to the denaturation of the proteins. These of the few examples are just here to highlight the property of lidocaine as a protein-bound agent. Bupivacaine is a long-acting amide which works by blocking the intracellular portion of the sodium channel to prevent the sodium influx, hence preventing depolarization. It has a longer duration of action than lignocaine, but it is cardiotoxic. Hence, it is contraindicated in the case of regional anesthesia, such as Beer's block, shall the tourniquet fails. The incidence of cardiac toxicity increases with bupivacaine due to its longer duration of action. This is because bupivacaine achieves a sodium channel blockade at a lower concentration compared to lidocaine, but stays in the cardiac muscle cells longer than lidocaine in a fast-in, slow-out fashion. Meaning that bupivacaine binds 10 to 20 times faster to a large proportion of sodium channels during the cardiac action potential, but releases from the channels slowly during diastole compared to lignocaine, for example, resulting in a large accumulation of anesthetic agent in the cardiac muscle cells, explaining the high risk of cardiotoxicity if used systemically. Lastly, Prilocaine, which also has a similar mechanism of action but far less cardiotoxic than bupivacaine, Hence, often it is used as anesthetic agent of choice in regional anesthesia. Local anesthetic toxicity is associated with central nervous system excitement and inhibitions, as well as cardiotoxicity by causing inhibition of the contraction of the cardiac muscle cells, as we mentioned earlier. It begins with paraesthesia around the lips, tinnitus, visual disturbances, then followed by dizziness, convulsion, arrhythmia, and lastly collapse. Intralipid IV infusion is the reversal agent of choice in the case of local anesthetic toxicity due to the lipophilic property of the local anesthetic agents. Here is a table showing the dosage guide of each anesthetic agent that we have discussed. It is also important to note that the actual dose is subjected to the site, the vascularity of the patient, as well as comorbidities. The next slide shows the total maximum permitted dose of an anesthetic agent, and these are based on the ideal body weight of a patient. Now, let's move on to the effects of adrenaline when it is used with a combination of anesthetic agents. Due to the vasoconstriction effect of the adrenaline, it helps to prolong the duration of action by reducing the rate of systemic absorption of the local anesthetic agent, hence permits a higher usage dose locally to achieve better anesthetic effects. This is of course an exception in the case of Bupivacaine. Still, it is important to remember that in the case of anaphylaxis in patients who are taking a monoamine oxidase inhibitor or a tricyclic antidepressant, adrenaline is still the treatment of choice in severe anaphylaxis. Now let's move on to the regional anesthesia. As we can observe in this diagram that illustrates a Beer's block, this is a technique commonly used in fracture reduction as it involves a deeper and wider area compared to local anesthesia. During a Beer's block, an intravenous local anesthetic solution is injected into a region. For example, this is an arm which has been exsanguinated by an inflated tourniquet for about 20 to 40 minutes. However, this technique is contraindicated in patients who are hypertensive or in patients who suffer from crush injury and where the IV access is not identifiable. Next up, we will take a look at the epidural anesthesia. The important point here is the insertion point of an epidural needle varies according to the desired dermatome level of the neuraxial block depending on the proposed site of surgery. An epidural space is defined as a space which extends along the entire vertebral canal between the ligament of flavum and dura mater. The injected anesthetic agents then spreads craniocaudally to penetrate the meningeal sheath that containing the nerve roots to achieve anesthesia effect at several dermatomes at a time. The advantage, or one of the advantages of an epidural anesthesia is that an epidural catheter can be left in situ to enable continual anesthesia if needed. Besides, it has shown to have a reduced post-operative risk of respiratory arrest compared to general anesthesia. The next diagram is roughly showing us how an epidural catheter can be placed into an epidural space. Epidural anesthesia can be the anesthesia of choice during lower limbs, pelvic, and often was also used during the labor. In spinal anesthesia, local anesthetic agents such as lidocaine or bupivacaine is injected into the subaortic space for spinal nerves blockade before they exit the intervertebral foramina as shown in the diagram. The aspiration of cerebrospinal fluid confirms the needle placement into the subaortic space. To avoid damage to the spinal cord, spinal anesthesia is administered below the L2 lumbar vertebra. It is also at this level the cauda equina nerves acquire their perineural coverings, as well as myelin sheath, as they exit the dura, making them exquisitely sensitive to the effect of the local anesthetic agent. As a result, a 2 to 4 mL of local anesthetic agent can produce a dense block up to a level of T6 with rapid onset of action lasting 2 to 3 hours during the surgery. Addition of glucose into the anesthetic agent solution with the help of the gravity can make the controlling of the level of block much easier. However, one of the more common complications of spinal anesthesia is hypotension. This is due to a reduction in sympathetic tone, causing splenic vasodilation and venous pooling. These can be managed with intravenous fluid or ionotropic support if refractory to fluid challenge. The next diagram is showing a technique known as combined spinal and epidural block, which has gained popularity over the years. It can be defined as the intentional injection of drug into subaortic space and the placement of a catheter into the epidural space as part of the same procedure. The advantage of combined spinal epidural block is that this neuraxial block can be achieved rapidly using the spinal component, while the epidural catheter can be used to prolong or modify the block. However, neuraxial block is contraindicated in patients with ongoing anticoagulation, presence of a local sepsis due to risk of introducing infection into the cerebrospinal fluid, or patient in state of shock or hypovolemia, in patients with raised intracranial pressure due to the risk of coning, and also in patients who are unwilling or uncooperative as it risks of failure. Lastly, it is also contraindicated in patients who have heart valve stenosis. This is because the condition renders the heart in a fixed output state, which is unable to cope with change in volume distribution, such as hypotension, where stroke volume needs to be increased in order to maintain the cardiac output. We then finally come to general anesthesia, which is a state of controlled unconsciousness under supervision. This is not to be confused with sedation, where the consciousness is not impaired. The level of general anesthesia is usually classified using Gödel classification by utilizing muscle tone, breathing patterns, and eye movements as parameters to determine the stage of general anesthesia. As seen in this illustrated diagram, stage 1 was marked by analgesia and maintenance of consciousness. In stage 2, the patient became unconscious, breathing became erratic, but delirium could occur. leading to an excitement phase. Moving on to stage 3, it is where surgical anesthesia occurred, with 4 planes or levels describing the increasing depth of anesthesia until breathing became weak. Stage 4 was marked by respiratory paralysis and death. Other signs included pupil size, newer anesthetics, and balanced anesthesia have rendered some of these signs less reliable. Thank you very much for watching, and we will discuss the anesthetic induction agents in the next tutorials.